I just want to acknowledge the experts that we've invited on this panel, Professor Odami, all the way from Canada, Anne Duncan, who's a dedicated clinical nurse specialist at the Royal Children's Hospital, and we have Dr. Chunda, who's joined us from Zambia, all the panelists and all the participants joining us as well. The doctors that have joined us together with Dr. Chunda, who are not on the screen, the PS, Dr. Malama from Zambia. So before we go ahead, I just want to acknowledge the traditional owners of the land on which we work, even if we're doing this virtually. I want to pay my respects to the elders past, present, and emerging. And as I said, we are doing this on behalf of Australian Sickle Cell Advocacy. And what we like doing before we actually start our program, we'll just simply tell you a little bit about us and why we are doing this. So I'll just quickly tell you that we are Australian Sickle Cell Advocacy. I'm the founder and executive director. My name is Agnes. I'm an RN by profession. I've done business and a data analyst. I came into the sickle cell space when my daughter was diagnosed with sickle cell disease about 11 years ago. And we've gone through this journey until finally we did everything in terms of treatment, she had a bone marrow transplant. And that's why we are here. And that came from a point of being a mom to being an advocate without even knowing. So who we are an advocacy group based in Melbourne, but we have chapters across all Australia and territories. We've got representatives. We are governed by a board, and right now we are governed by Dr. Margaret Evans-Kalia as our interim chairperson. We've got scientists, and we've got people from public health who are part of the board. Myself and Preston, my husband, and Natalie, we founded this organization. And for us, basically, our mission is just being the best that we can to be a leading advocacy organization in Australia for the people who are affected by sickle cell disease. And we do much predominantly by supporting the people that are affected, because we didn't have the support when I was going through this for the past 11 years. We do this observing our 4 core values, which are excellence, perseverance, integrity, and caring. And so we have representatives that I was going to show you the screen because we are running a bit late. I was going to show you the team in South Australia who are coming up, and we'll be doing a launch next week, but we'll do that, I think, tomorrow. And quickly, I always say that why do we do this? For us as an organization, we've realized after doing a study that the numbers of people that are affected by sickle cell disease is increasing. And we are doing this because all of us in this group, that we've got a story to tell. We didn't know that we carried the sickle cell trait. No one reminded us to get tested until we had a child. That's when we are told that, by the way, you have this gene that would have tested a long time ago. And that's why we're doing this. You see this graph of the census that we carried out. We looked at the numbers are growing, and if you come from these countries, you're likely to have the sickle cell trait. And basically, that's why we're doing this. So today, I've got my co-host, Mrs. Mwansa, hosting with me. And at this point, I will get Mrs. Mwansa to introduce herself and let the other panelists also introduce themselves. Thank you.
Thank you, Agnes. This is such a fantastic idea. And I personally am Sylvia Mwansa, who has got a warrior. I'm sitting with him today. We're giving each other some love. And, I've been a caregiver for the last 33 years. And I find myself having this, passion to just make sure people know what this sickle cell disease is. I'm a mother of 4, and one sibling is the one with SS. And I find that it is very important for me as an entrepreneur, to make sure that as I do my business, I'm aware of what's going on at home. And this is why I'm so excited about being part of these sessions as a caregiver. And I've learned a lot, and I'm yet to learn more. Thank you, Agnes.
Thank you, Mrs. Mwansa. At this point, we'll just go through the panel for 1 minute before we start the main presentation by Anna, to just quickly introduce yourself and how you are affected by sickle cell. I think I'll start with Professor Odami, just a few minutes, then we'll go through everyone introducing themselves. Thank you.
Hi, everyone. I'm delighted to be with you today. I'm a pediatric hematologist and the chair of hematology in the University of Toronto. I'm based at the Hospital for Sick Children in Toronto. And I'm also medical director of the Global Sickle Cell Disease Network. I spend most of my time looking after patients with sickle cell disease, being involved in clinical trials, looking at novel therapies for sickle cell disease. I'm originally Ghana born and very much aware of the burden of the disease in Africa, and also people who have migrated from Africa to other parts of the world. Thank you for having me.
Thank you. Anna, would you like to introduce yourself? Thank you.
Yeah, thanks, Agnes. So as Agnes said, my name's Anna Duncan and I'm a clinical nurse consultant at the Royal Children's Hospital in Melbourne. So we're a large paediatric hospital, and my role, which has been established only for sort of less than 2 years, I've been doing this role. Before that, we didn't have any dedicated nurses for the care of sickle cell patients and their families. So my role came into play when our sickle cell population has sort of been increasing over the last decade or so. We now care for about 50 patients with sickle cell disease at our centre. So I work closely with one of our paediatric haematologists who's a clinical lead for sickle cell disease. And yeah, we work together closely to provide sort of all the care for our sickle cell patients and their families.
Thank you, Anna. Dr. Chunda, would you introduce yourself, please? Thank you.
Thank you very much, Agnes, for the invitation to be on this very important meeting. My name is Catherine Chunda Lioka. I am a consultant pediatrician. I work at the University Teaching Hospitals, the Children's Hospital. I'm currently in charge of the Department of Pediatric Hematology in that particular unit. I also happen to be chairing the task force that has been given the mandate to actually come up with a national program for the country. That is in terms of my work. At a personal level, I do come from a family that actually carries the gene for sickle cell, and I actually have quite a number of my relatives that suffer from the disease. Thank you very much again, Agnes.
Thank you. Gautam, would you introduce yourself? Thank you.
Hello, everyone, and this is good afternoon from India. And I am Gautam Dongre. I am the father of 2 sickle cell warriors. My son and daughter both are sickle cell warriors. And I am a passionate for awareing sickle cell disease in society as well as for education. And I am also associated with number of societies, number of patient groups for the awareness of program in India. So thank you very much, Agnes, for having me here. Thanks a lot.
Thank you. Sophia, would you introduce yourself? Thank you.
Thank you, Agnes, and thank you for the opportunity to be a part of this special presentation this evening. Hi, everyone. My name is Sophia Anna. I'm 27 years old. I'm from South Australia, and I was born with sickle cell anemia. I've had it my whole life, and as a result of that, I'm a huge disability advocate and run a YouTube channel that raises awareness about invisible illness and sickle cell. Thank you.
Thank you. Yemi, finally, would you introduce yourself? Thank you.
Hi, good morning all. My name is Oluyemi Moses. I am a sickle cell disease patient. I came from a family, 4 of us had sickle cell disease. 2 of them have passed away. My older sister and younger brother passed away of sickle cell complications over the past couple of years. I have another brother who was lucky enough to have a successful stem cell transplant. So currently I'm the only one in the family who has sickle cell disease, and I have become involved in several different groups, advocacy groups, just to not only get my story out there, but to help sickle cell disease patients as well. Thank you for allowing me to be part of this group.
Thank you, Yemi. Mrs. Mwansa, would you give us an overview of the topic that we have today? Thank you.
Thank you so much, Agnes. The topic today is we're discussing on sickle cell disease awareness, and in particular today's topic of dedicated hospital or ward and pharmacy to sickle cell disease warriors and caregivers. This topic is very, very important in that whether, because sickle cell is a lifelong disease, and whether we like it or not, one day or the other, if you're affected, you are bound to be in tandem with what is going on in the world. So since it's a lifelong disease or disorder which no one has control over, and that whether we like it or not, it will be there. Therefore, it is very, very important to have a space for it, and not just a space for it, but a safe place where you can be, so that you are aware of, everyone that is around you is aware and feels comfortable to go, and assurance is there that gives us comfort, that we are going to get dedicated support, and the people that are around us understand. We don't always have to start the story from beginning to end. When we are in crisis, our minds are scattered, and we just want that help. And when you go to these hospitals, sometimes the person that you are interfacing with, you have to start the story, and meantime, your child or yourself, you need that support immediately. So, so the doctors, the nurses, and caregivers, and everyone in there have to know what we are doing at a certain, immediately when we arrive at the hospital. So that's why this topic for today is very close to my heart. Having been in it for the last 33 years, I believe that a dedicated space will be something that we all need, so that we can just feel safe and receive the immediate attention that we might need. So in saying that, I would like now to just give Agnes to add to her perspective, because she's been doing this for a long time, and she's got a lot of issues that we've discussed in the past, and today it is just that day that we have to discuss this dedicated space for sickle cell warriors and caregivers. Over to you, Agnes.
Thank you, Mrs. Morris. Before I give my perspective, I'll just get Musonda. She's finally managed to join us to introduce herself. Dr. Mwilwa, please introduce yourself. Thank you.
Thank you very much. So sorry for having an internet problem. So my name is Dr. Mwilwa. I'm a medical doctor practicing at UTH as a junior resident doctor, and I'm living with sickle cell anemia. So I've been living with sickle cell anemia for the past 29 years old. So, and sickle cell is what inspired me to be a doctor, because even as a child, I would just tell my mother and my relatives and say, I want to be a doctor so I can help people like me, because to me, the doctors were my heroes, the nurses were my heroes. I knew that whenever I went to the hospital, I'll be fine. That pain will be taken away from me. So I'm very passionate about sickle cell anemia, and I really appreciate you guys making me part of this forum. Thank you.
Thank you. Your internet is quite bad. Hopefully it improves as we go. So before we bring into
Okay.
Anne, who's going to do a PowerPoint presentation, I felt, for me, I'm lucky to be here, and I'm lucky that I've got Anna, who and other places I've been in Australia, from Perth to Sydney to Melbourne. We all had a form of dedicated people that we used to see, and but that's for me because I'm here in Australia, and we're lucky that we are here. So I feel dedicated support for sickle cell warriors serves as an ongoing management strategy for people affected. Continued monitoring with a group of different disciplinary teams we can ensure that they know what works for patients and their history. I also feel people affected by sickle cell disease always have, they've reported bad treatments they receive from institutions, especially if they can't tolerate certain quantities or qualities of, things that they go through. One of the examples is pain. Pain is a big issue, as we know, for people who are living with sickle cell disease. And, having that personal relationship with the doctors that you are seeing regularly can reduce some of the misconceptions, like what we discussed in the first week, some of the things that people that are living with this disease, they spoke about, that one of the things they are told is that they are drug users, or they are opioid users. And once we have a dedicated team to look after the certain patients, they'll know like their pain tolerance and what medications works for them. Pain is subjective, and people, characterize pain differently. You might see the person the way they look, and I've seen literature where they say Black people don't feel pain, or the way they portray themselves. I don't know how they are supposed to portray themselves. So I feel having a dedicated team of doctors and nurses looking after these people will eliminate those misconceptions. But this also goes on to good transitioning to adults, because the patients, there'll be that good transition between the doctors and the nurses from the kids clinic to the adult hospital. There'll be a smooth handover from the doctors who have been treating these patients for years. Also, if we have dedicated centers for these places, we'll have proper data collection, which will be possible and easy to have patients, because patients will be coming in regularly to these dedicated centers. When we collect data collection is good or essential for clinical trials, to pharmaceutical companies. They want to bring medications to countries where they know, unfortunately, that they're going to make money. So we have the dedicated centers, will be easy to collect that data. But also it gives those countries, if we have these pharmaceutical companies to come to countries, there'll be medications being offered to countries. For example, here in Australia, I can tell you that we don't have all the medications like places like America and the UK, because they want the numbers, and we're only about 1,000 of patients that are living in this country. And so it also goes to access to care, because those are some of the subtopics. Access to care comes from all these things that we've discussed. Because if we don't have enough data, we don't have enough medications, then it leads on to poor quality of health with people living with sickle cell disease. It also goes into access of care, not only due to medications, but all these subtopics. So in turn, it goes on to people having increased mental health issues, that also impact on their physical issues. And so if we work together, starting with creating simple dedicated centers, this can go into a long way to ensure that we have good quality of health for people living with sickle cell disease. And so this is why we felt, out of all the topics that we came up with, we thought this was a very important topic. If we address all these things, we are basically addressing most of the things that actually affect a lot of people. That's just what I thought, and that's just my input as a caregiver. I can't even imagine what people who are actually living with this disease go through. So that's my take. But at this point, I'll give Anna the co-hosting powers so that she can do a presentation for us before we go into bringing on the panel to discuss this topic. So Anna, over to you. Thank you.
To unmute myself there, I'll just share my screen. Hopefully, tell me if this works, Agnes. So how's that? Is my screen shared with you now? Yep. Okay. So hello again, everyone. And as Agnes has introduced, my name's Anna Duncan and I'm a sickle cell disease clinical nurse consultant, which was the first dedicated nursing role for the care of sickle cell patients in Australia. So we have other haematology sickle cell or haematology clinical nurse consultants, but they sort of spread themselves over other haematological conditions. So we're really lucky now to have this dedicated role at our hospital. So I work at the Royal Children's Hospital in Melbourne, and we treat around 50 patients with sickle cell disease. So compared to North America or the UK and other parts of the world, this is probably a relatively small population. But to put that into perspective, 10 or 15 years ago, we had around 5 patients with sickle cell disease, and now we have 50. So it's certainly a growing population in Australia. So really important to have, as Agnes said, these dedicated clinicians with a passion for sickle cell disease and caring for these patients and families. So the focus of my presentation today is transitioning from paediatric to adult care. And so Adolescent Transition, what is it? It's a purposeful planned process that addresses the medical, psychosocial and educational needs of adolescents and young adults with chronic physical and medical conditions as they move from child-centred to adult-oriented healthcare systems. So this definition highlights that this is not a simple process and there's many factors to take into consideration for it to be a smooth process for everyone involved. At our hospital, so some centres treating children with sickle cell disease are whole of life centres, so they just move up through the same hospital and transition isn't as big a process. But at the children's, like many hospitals around the world caring for children with sickle cell disease, we're a paediatric healthcare provider and typically treat patients from birth to 18 years or once they've finished school. So this dedicated service at our hospital was established in 2010 and we see over 2,500 patients a year with our service. So they're children with chronic and complex health conditions. So of course that includes sickle cell disease and then other associated developmental disabilities, intellectual disabilities, autism and mental health or behavioural concerns, which can affect patients with sickle cell disease just like anyone else. So our transition team is a multidisciplinary team that reflects all the complexities of this process. So we have a transition manager, which is a full-time position, and then support coordinator, support workers, a youth mentor, social worker, and a research coordinator. There we go. Is that still sharing? I'm not sure. Can you still see my screen?
Yes, yes we can.
Okay. So transition support at our hospital, so it's preparatory holistic support, care coordination, early transition planning. We have joint clinics across multiple departments between the paediatric and adult centres, establishing partnerships with all medical and surgical teams that are involved in the care. And research is really important to keep up to date with international best practice so that we deliver the best transition process. And of course it's incorporates consultation and education to other health services. So the aims of transition are to provide quality healthcare appropriate to each patient's age, their culture and their development, and it has to be dynamic and flexible and relevant to each patient's individual needs. We help the patient to develop skills in communication, decision-making, assertiveness and self-care, determination and advocacy. We aim to enhance a young person's sense of control and independence regarding their healthcare, maximising their capabilities to live well and achieve their goals regardless of their condition. We provide support and guidance for the parent and carer, and recognising that this is a process that involves not just the young person or the patient, but everyone has to understand, and parents and carers understand that their role is changing. So for parents and carers, it's a really important process to go through, encouraging their child to take charge of their own healthcare and become more independent. And the parent's involvement is really important part of this process to support the young person during a huge change, and the transition process helps everyone cope with this time of change and the changing roles and the family dynamic. So there's several phases in the transition process, and the first of which is the introductory or planning phase. So this starts at around 12 or 15 years. We introduce the concepts of transition, starting the transition discussions, bringing in that information, do a psychosocial assessment and assess the young person's knowledge of their medical condition and how they manage it, and identify any gaps and how to address them. So this is our hospital's checklist. So this is before even the first appointment, and this helps to identify all the care providers that are involved, whether they're in a private clinic or external to the hospital. And as we know, it's usually not just a single team or a doctor involved in the healthcare, it's a list of specialties involved with sickle cell disease, and we make sure that they're all linked in with when transitioning into adult care. It's really important to know where the family want to be treated in the adult world. You know, do they want to be up at the main hospital just up the road that's close to our children's hospital, or do they want to see some specialists who are closer to their home? However, some of the treatments, such as red cell exchange, apheresis, or blood transfusions, aren't available at every hospital, and so that might limit where you can transition to or where you can have those particular treatments. So at the preparation phase, it's sort of between 13 to 18 years, and we start developing a transition plan and assign a transition support person who'll help manage the transition process. The young person's offered consultations with their clinician independently of their parents, and this helps to develop the self-management skills and introduce the concept of confidentiality, and the correspondence from the hospital might start to be sent directly to the patient. So the parents are encouraged to be involved and ask questions and raise any issues in this phase as well. So this is our checklist for the first transition appointment, and as you can see, it's a comprehensive first appointment with the team. It's a really good way to identify and address any issues early on. So there's a range of specialties involved, and the transition team will get consent from the patient and the family to contact new healthcare providers in the adult world and refer the young person. So this also helps with knowing in the future when you're an adult, how do you access disability funding, for example, and do you know how to access any additional supports you need? How do you link in with a physio or a dietitian, a psychologist? How do you get social security? Do you have a bank account? Can you use public transport? So there's a lot of important things to cover to make sure we do foster that independence. So the transfer phase might not always occur at 18 years. For example, if they're completing school a bit later, they're 19 or 20, they might transfer when they're a bit older, or some of our young people transfer before their school's completed. But it's really important to recognise that the same education and support that we provide at our paediatric hospital isn't always available in adult healthcare, and that's why patients will often stay at the paediatric centre until they've finished school, so they've got that support. And at our hospital, we're very lucky, we've got an education institute on site that provides assistance with all sorts of things, from getting special consideration and extra time in exams, and special sort of consideration when grading exams. And they liaise with schools and advocate for the young people with sickle cell disease. And we have on-site teachers that help with missed school attendances. So when you're admitted for a crisis or for whatever reason, you can still attend school or have a teacher in the hospital. And for our kids that are on chronic transfusion or exchange therapy, they'll have a teacher, so because they're probably missing a day of school every month, which really adds up. And then, so in this phase, we also assess how ready the young person is to transfer, whether they've finished puberty and have they developed a reasonable level of communication. And so this is a follow-up after the initial appointment to identify gaps during that transition appointment, and we get the family and the young person involved to help with their independence and knowing how to ask for help, which is really important when you move into an adult centre. And the evaluation phase happens after the transfer, usually between 6 or 18 months after they've transferred. The patient is considered to have transferred from a paediatric centre after they've had their first appointment or treatment at the adult service, and they have no more appointments booked with the paediatric service. And we always say, you know, it's really nice when our patients and families will come back and say hello, because, you know, we've developed relationships over years, and it's really nice when we see you and hear how you're going out in the adult world. So, of course, transition can present significant challenges, and it's why it's such a considered process that begins well in advance of transition. So they're going to a new service and it's unfamiliar. Communicating between different adult services, they need to learn how to do that. Transferring all your healthcare information up to a new centre to the care of new doctors who you might not have known your whole life as you have when you're at the Children's Hospital. It's a time to take responsibility for your own healthcare, negotiate your independence and navigate through different healthcare systems that have different expectations of you. So how do we overcome these challenges? Well, planning for transition early, developing self-management skills, set achievable goals and work towards them. You know, do you know what medications you take, what they're called and what dose you take? You know, who do you call and what do you do if you're sick? Do you know who can support you and the resources available? How do you advocate for yourself in the healthcare system? And at our hospital, what we do, I will often go when our young people transition up to the adult hospital. I might attend the first appointment with them, or we'll go and tour the day medical or apheresis unit so they know where they're going to have their transfusions or red cell exchanges. And yeah, I'll often attend the first clinic appointment with their new nurse or haematologist up at the hospital. So these are some points to run through and check for readiness. So do you know about your sickle cell disease and the treatment? Can you describe your disease and any other health concerns? What medications you're on and other treatments? How often do you need blood tests and to make appointments? It's really important to provide education around risk-taking behaviour and how do things like alcohol and smoking and illicit drugs affect sickle cell disease, and make sure we've had conversations about sexual health and reproduction and considerations for when starting a family, like genetic screening and stopping medications, and that sometimes your disease can get worse when you're pregnant. Are you independent with your healthcare? Who gets your medications and fills your scripts? Who do you contact if you have a problem? Who makes your appointments? Do you feel comfortable advocating for yourself? And do you know your rights and responsibilities? Staying well. Do you know what symptoms to look out for and monitor them? Do you know who to contact 24/7 to find urgent medical care if you need it? Do you have psychosocial supports in place? And do you have access to educational support, peer support, wellbeing support? Because they're all just as important as your medical care. And then planning for the transfer. You've got your transition plan and you've discussed it with your treating teams and made sure there's no gaps. Do you have your correct contact details in the referral letter? Do you know the new healthcare team contact numbers? How do you get to your new hospital or healthcare service? And do you have your own trusted GP? This is a healthcare skills checklist that we use at our hospital. This is a generic one that's used across all the patients, no matter what their background or disease or condition. We use this checklist, and in preparing this presentation, I've realised that we don't have a dedicated sickle cell transition passport or checklist, and now I've identified this gap and I'm motivated to go and develop one for our young people. So I'm hoping to make our transition process even better for sickle cell disease. So just to sum up, with transition, preparation is key. So start the process years before transitions due to occur. Identify the issues and address them early. Young people and their carers should all have an active role in the transition process. The timing of transition will be dependent on the individual. Transition will encourage independence. It'll help set achievable goals and help to achieve them. It should be an enjoyable process, a way to identify your strengths as well as the gaps and improve on them. And yes, there will be challenges, but your healthcare team are here to help. So thank you, everybody. And are there any questions?
I think we'll leave the questions at the end, Anna. So
okay.
I'll get Mrs. Mwansa just to summarize before we bring in Professor Odami and Dr. Chunda just to give their perspective in terms of transitioning We have subtopics. So what we thought was first after the presentation, then we bring in the panelists to discuss. So Mrs. Mwansa, please, thank you.
Thank you so much. This has been such an eye-opener in the way that she's really tackled it. Like she's covered everything. We've heard that in the beginning, they used to only have 50 patients. They used to have 5 patients, but now they're seeing 50 patients.
Sorry, Anna, would you just stop sharing the screen? Sorry, Mrs.
Oh, yeah, I can't. I'm trying to work out how to get you guys up on the big screen and stop.
Just stop sharing the screen on the
top. Yeah, there we go.
There we go. Yeah, right. Okay. All right, thank you.
There we go, that's better.
Thank you so much, Anna. That was really an eye-opener. And you've said it all, that, all these things that we're talking about are real things which you have experienced. And it just, means that, the people that are listening and the people that are on the panel really have gotten, the issues that are at hand. And we've heard how, in the beginning, you only saw 5 patients, and now you're seeing 50 patients. We have heard that before you started, it was really minimal, and now you're seeing 2,500 patients in transition service each year, which is really, really a big number. We've seen the importance of transition team, because the transition team is there full time, and they're able to really, give us the options and prepare us for, for the transition. We've seen, the aims of you've talked about the aims of the transition, which is basically to provide high quality care, to warriors. We have also learned that you really do the planning, planning the transition, which starts at 12 years. And that gives us really a good reason for us to know that these things come with planning. And for me, it really got my attention that without planning, you would never know how many people are affected, how many people you are taking care of, and how many people are really finding pleasure or challenges in the system. So the pre-planning session before the first transition, you talked about it as being very, very effective and important in the way that we are able to get to, to help the warriors and the caregivers. We have seen that during the preparation phase, it is also for parents and for caregivers, because as it is, especially in my country, the caregivers are really like not part of the system, so to speak. But if you plan with them, life becomes easier to deal with. We have seen that you have the checklist. This checklist makes everyone know that everything is taken care of, be it access, to future needs. Because this is what happens. If you do not have history, then it's a big, big problem, to deal with the coming admissions and transition, as it were. So the checklists have found that, that's something that everyone probably needs to be doing in this preparation. You talked about the transfer phase, and this is just telling you how ready are you, or how ready is the young person to be transferred, because we really get to misunderstand that maybe, the caregiver is ready because they know that their child is 12 years, so they are ready in their mind that they need to be transferred. But the warrior himself or herself probably is not ready because they're very comfortable from where they are and they don't know where they're going. So this being ready is very important. You talked of challenges. Challenges are good to know, because challenges give you opportunities to do something better. And like you just saying, this is a problem. Problems will always be there. But when you call them challenges, it's giving everyone, this leeway that there is an opportunity. And for us who are here listening to you, these are the opportunities that we're looking at so that we can improve something in the long run. And so, are you ready? Is what really also inspired me in your sharing. And as you gave your summary, that preparation is key, so we're supposed to be ready for it. Identify issues and address them early. Young people and caregivers should all have an active role in the transition stage. You said that timing of transition is very, very important, because if you do not know how to time the, the transition, then you'll be thinking that things are really difficult. You talked about the transition will encourage independence, and this really is a great deal of everything that we've talked about. Because if children or the warriors are not independent, the caregiver will have no space. They will be overwhelmed in the way that they deal with the warrior. So transition will help set achievable goals and help achieve them. That is really like great in your summary. Transition should be enjoyable process. And if we can enjoy this, because it is with us, it is a long-term thing. So we just have to enjoy, the process, so that we are able to achieve our goals in the way that we have prepared, our mindset, because everything is there. And if we don't enjoy, it means we're going to have a very, very miserable time. So I like the process, the transition, where you say you have to enjoy the process for the caregiver, for the doctors, and also for the patient, himself or herself. So because we know that there will be challenges, but our healthcare team are there to help us. Are they there to help us? Yes, we have to have a give and take, whereby we understand. And this is for me why it is so important to have this dedicated space, where caregivers and nurses and doctors can have a uniform way of dealing with the challenges. That's what I got. I was typing very fast, and I hope I got everything that you talked about. And that's what it is, that I captured. Thank you. Agnes, do we have to say anything about that?
No, thank you. I'm just being mindful of time. So at this point, we are going to bring in our panelists. So I'll just remind everyone that, so we divided this topic into 5 subtopics. The importance of having a dedicated hospital ward, dedicated pharmacy store for sickle cell, transitioning, which was our main presentation, and strategies and advantages of building a database for sickle cell warriors, and also access to care and physiological effects that comes with having no access. So at this point, I'll just give Professor Odami to give his overview on the topic before we go into detail now for the panelists to actually give their views. So Professor Odami, please. Thank you.
Thank you very much. I think being aware that we're dealing with different health systems. So we're dealing with high income countries, middle income countries, and low income countries. And having traveled globally, I know that the challenges are different in different settings. So I can see somebody has asked a question that how do you do transition in a low income country where the system is so weak, there are no adult programs, and you don't have a well-structured, dedicated system that ensures transition. So I think the question about having dedicated centers is so critical, but we should never look at dedicated centers in isolation, because the majority of people with sickle cell do not live close to these so-called centers of excellence. So they live far away, and they cannot utilize the services of these centers of excellence in a regular way compared to those who live near. So the centers of excellence should be linked with other centers in the periphery, in the secondary and primary settings, so that the knowledge and expertise of the people in the centers of excellence can be shared with the lower centers of care. Because in emergencies, patients will go to the nearest place for care. They cannot travel long distances. So I think when we establish centers of excellence, one of the mandates that these centers should have is that they should in turn empower and train people in lower centers of care, so that from tertiary, secondary to primary level, the knowledge is shared, certain acute emergencies can be handled, and then patients can be referred up the ladder depending on what complications or what problems they have. So we should always think about the systems Fortunately for us, many sickle cell patients live in metropolis. They live in big cities and big centers. But let's not forget those who live in rural areas, those who live in places that cannot have easy access to these centers of excellence that are usually centered in tertiary centers. So the whole system has to be joined together. And I have to say, to make this happen, sickle cell warriors have a big role to play, because for a service to be impactful, it has to be available, it has to be affordable, and it has to be a quality service. And if it's going to be quality, one of the main things is that it has to be patient-centered. It has to be tailored to respond to the needs of the patient, the values of the patient, the values of families, and also that their interests should drive the care, and they should be part of the decision making. So I think warriors in every country need to step up, because they know what they need. They know what it is like to live with the disease. They know where the deficiencies are, and they have to be at the table when these systems are being planned. So these centers need to be set up, and then the providers need to partner with the warriors and their families, and also policymakers, to ensure that policy changes happen. So it's a big, big step to establish centers of excellence where they don't exist. And where they exist, my plea is that these centers of excellence should see as part of their mandate that they will train, educate, create guidelines, create tools for other lower centers of care to be able to deliver the same quality of care closer to where families live, so that families will have access to good quality care that is affordable. That's just my short comment on establishing dedicated centers and how they can become accessible to patients and families. Thank you.
Thank you, Professor Odami. That was very insightful. We are mindful that we've got experts on this panel, and Dr. Chunda is supposed to exit in a few minutes. Dr. Chunda, I'll just give you a few minutes before you go, just to give an overview before we bring in the panel to discuss the other topics. Thank you.
Thank you very much, Agnes. And to Professor Odami, thank you for those comments that you've made. I must mention that I'm honored to again have this opportunity to interact with you, this time on this forum. The comments that he's made are really things that we should be considering as we discuss this topic. And in the forums that I've actually interacted with Professor Odami, this is something that has really come out quite significant, that as countries, as continents, we are all at different levels in terms of development of our healthcare systems. And within Africa, you find hematology services that are really in their infancy in most of the countries that you interact with. And it's actually not just hematological services, but let me just say the specialized services, including cardiac, renal, and others. And because most countries are in their infancy, you find most centers might just have a pediatric unit, or it may just be a hospital that everybody goes to, and the only thing that will separate them are wards, and not necessarily having those specialized services in the country. And as we've been having these discussions, one of the things that has come out is actually the need to begin to recognize hematology services, and sickle cell disease in particular, because it seems to be the one to stand out among the hematological diseases that we need to be paying attention to. This is something that is coming up. And for most countries, what you will probably find is a hematology unit that will provide both the inpatient and outpatient care services. We do recognize as well that even within these services, most countries are struggling even just to diagnose the disease. so that most of the patients they have that are caring for are patients who came having had complications already from the disease. It was not diagnosed at the time they were born. And so that is one thing I'll tell you, most African countries are going through right now, just the struggle of diagnosis. And so it still remains quite a challenge to have all these small, very important services that are needed to be in place, to have a transition unit, to have all the medications that are needed, to have diagnostic services, to have counseling services, to have premarital counseling services. So most of those are actually just at the point they are actually beginning to put the services in place. In terms of what's happening in Zambia, now that we've had our national guidelines launched, these are some of the things that we've actually put in place. We would like right from the beginning, as women are attending antenatals, awaiting delivery, they should know their sickle cell status so that as their child is born, we actually target that child and consider screening that child. We are in the process of beginning newborn screening within the country. And right now, we're actually advocating for routine screening, just like we're doing HIV screening within the country. And just to narrow in on the discussion on transition, as a hospital, we've actually recognized this is a service that is lacking. And so we've put a protocol in place of how we're going to be transitioning, not just the sickle cell patients. Of course, they've been identified as a lead group, and we are hoping as we begin the process, other units with patients with chronic conditions like heart, renal, will learn from us and to actually adopt the same. For the HIV group, they've actually done this very successfully, and we're trying to learn lessons from them. And so it is a service that we plan to actually begin to introduce, even as we introduce all these other services that are not there, like newborn screening. I think I'll end there for now.
Thank you, Dr. Chunda. I think at this point now we are going to bring in, before I do that actually, we had Natasha who had difficulties to connect. Natasha, can you introduce yourself just 1 minute before we go into the panel of caregivers and people living with the condition to come in? Natasha, 1 minute, less than a minute. Natasha, can you hear me?
Hello, everyone. Yes, I can hear you, Agnes. Hi, everyone. I'm Natasha Kashito from Lusaka, Zambia. I am an adult living with sickle cell and an advocate. I'm so happy to join you all today. I was having some problems, but I hope I can stay to the end. This topic is really dear to me, and I'm sure to other sickle cell patients like warriors. And I'm excited to be here.
Thank you, Natasha. At this point, Sister Sylvia, do you want to come in? We're going to the questions. Sister Sylvia, are you there? Okay, I can't see her. Before we do that, actually, Anna, can I give you just 1 minute to just summarize the topic? The topic is dedicated nursing, dedicated support for sickle cell warriors. Apart from transitioning, everything else that Dr. Chunda and Professor Odami has talked about, what's working, and is there any areas you feel is missing at the Royal Children's?
Thanks, Agnes. So I think it's as I said, it's a relatively new role. So it's been at the Children's Hospital for less than 2 years. And I think in that time, we've already seen some big changes just in the way we run sort of our clinics, and now the patients and families get to see a nurse as well as our hematologist. And I just think from my point of view, and I hope our families feel the same way as well, that it just helps to navigate the way through all the appointments and admissions and things like that better by having someone that they can contact. So often the consultant hematologist isn't always available because they're really busy, as we know. So I think it just provides another point of contact just to help with day-to-day appointments, but also being an advocate within our hospital. And you know, if we need to make changes to appointments, we can do that. We have that flexibility because we understand that, you know, life comes up and we need to make changes, and people can't always make appointments. So from that perspective, I think it's a really valuable role to have this dedicated sickle cell nurse. And what is another really important point is to educate other healthcare workers. So as I mentioned, in Australia, it's definitely an emerging condition, and we're seeing more patients, more warriors that have sickle cell disease in Australia. And just to have someone to provide education to other doctors, other nurses around the hospital and within the healthcare system about sickle cell disease, because it's not really something that is even studied a lot in medicine. Until you're working in the area, you may not know so much about it. So I find just being able to educate nurses on the ward really helps for when patients with sickle cell are admitted, because there's certain things that they just don't know about. They aren't familiar with the medications or side effects or other symptoms to look out for. So I think that it is really important, and it just helps flow through the healthcare system. It helps to prevent a lot of unnecessary things when they're in hospital, investigations, and we can sort of streamline the flow through the healthcare system by having an advocate. So yes, I think it is a very important thing.
Thank you, Anna. I think at this point we'll bring in, just going by who I can see on the screen, Sophia. Briefly, just talk about the dedicated part before we go into the subtopics. Why you think it's important for sickle cell warriors? So we'll just go across. I'll start with Sophia because you are the first one I can see on the screen. Thank you.
Thank you so much, Agnes, and I'd just like to thank everyone who has done their presentations thus far. I really, something spoke to me in what Anna presented with regard to the holistic approach with sickle cell. In terms of dedicated support, I mean, we see that some of the research shows that some of the main barriers to caring for sickle cell disease patients is provider familiarity and lack of, so your doctors chopping and changing, and obviously an insensitivity and interpersonal care in adult settings, so not always having the continuity of care that you require. And I think dedicated support is about accessibility, and I'll give you a quick example by what I mean. In terms of this year, we've all experienced what's happened with COVID-19, and in England, the NHS sent out a letter to immune-compromised individuals, including sickle cell patients, to warn them that they are at high risk, so they'd be required to stay home. Now, I realise that here that level of protection wasn't as required because, you know, obviously our cases were quite low. Having said that, it was very hard to find any kind of information regarding your risk level as a sickle cell patient, whether it was safe to go to work, etc. And so I myself, from a personal viewpoint, found myself trying to find any semblance of information. I couldn't get in touch with my clinical hematologist. As Anna mentioned, they're quite busy. And so in reality, it was my endocrinologist who, after a few months, advised me that I was safe to continue working. So I think that continuity of care, obviously that's just one example of how fragmented our healthcare system is, but having that continuity of care for patients so that they feel that they have someone to go to in times of need, and especially this year in times of an emergency. Thank you.
Thank you. I think, Sonda, what can you give from the Zambian perspective? What do you reckon, why is it important to have dedicated support for sickle cell warriors? You are mute.
Okay, so I was saying, I hope it's very important to have a dedicated support because sickle cell is something that's it's what can I say? Your mental state isn't okay, but it's not easy to go through so much pain that you don't have control over. And it's always important to have that person that is there, and then where, like she said, where you can have someone to talk to, someone you can call, someone you can complain to, say this is what's happening, and then yeah, basically that's what I can say.
Okay. Thank you. Gautam, as a caregiver in India, what have you seen? Why do you think it's important for your kids to have a dedicated support? And is that available in India? Yeah, mute, sorry.
Thank you, Agnes. Dedicated support system for sickle cell disease is very important in India, because the population of India is now 1,369 millions, and out of that 1.4 millions are sickle cell warriors, and 18 millions are the carriers. So the huge amount of sickle cell warriors are in India, and all are situated, maximum sickle cell warrior are situated in the rural area of the India actually. And as we say that 66% of population of India is living in a rural area. So we have a dedicated support system, but very less amount of. Now our government is very positive to quality of life of sickle cell disease. Now they are trying to making some policies, and they are in process. I would like to say that there is a huge hope of improvement for SCD. Now, actually in our country, it has not received the priority basis and attention, not taking attention for the SCD. But now the government is taking initiatives by the help of tribal minister and also by the health minister. So, and here right now the scenario is the support system is collaborate with hemoglobinopathy, all sickle cell, thalassemia and hemophilia, including they are providing. So we need actually a special dedicated support system for sickle cell only, because when a patient goes in a crisis, he needs each and every treatment, medication, pathology, diagnosis in a few minutes, in a few time, because sometimes a patient doesn't have a time to live. So we have seen the lot of cases. The mortality is also very high. We have seen lot of cases due for the time being, they lost their life. So in last, I would like to say that in not only in India, but every part of the world, there should be a dedicated support system for the sickle cell disease, where the sickle cell disease is strong. Thank you very much, Agnes.
Thank you, Gautam. Yemi, do you want to just give your overview, please? Thank you.
Good morning. Yes, I agree with what everyone said. Sickle cell is such is a disease that affects people in so many different ways. So it's critical that patients do have a dedicated support, support from the family, support from the community, support from the providers. It helps to a degree, soothe the patient. You know, we're going through pain, we're going through so many different symptoms and so many different things as a result of this disease. And so to have dedicated support, to have a team that is constant, to have a team that's consistent, to have someone that we know is there for us, who understands us, who knows what sickle cell patients are going through, who knows what they're dealing with, who are able to coax us and help us and treat us, care for us, speak to us, encourage us, is so critical for sickle cell patients and for the well-being of us. of our mindset, of our health, of our families, I think is very, very important. Thank you.
Thank you, Yemi. Go ahead, Mrs. Mwanza. Topic 3, please.
Okay, because we've seen the importance of the segment that we've just been talking about, and this is what it is, and everyone who has listened and who has had the opportunity to be part of this has seen that now what remains is just to change the narrative. Wherever we are in this chain, be a warrior, caregiver, and those enriched with preparing policy to make things happen or desired by everyone who is affected by sickle cell disease, whether now or in the future. Well, now it's time for our next topic, which is transitioning from pediatrics to adults. And this we've already heard from Anna, and we just go straight into asking our experts. I don't know whether we can start with Professor Adame, a hematologist, to see what benefits have you seen with having a dedicated program to transitioning children to adult hospitals. Do you think this is happening in most African hospital settings? Or maybe before we do that, there was a question that we asked Anna as an expert to let her indicate, because she's seen a lot of kids out there, and also what she thinks about this program, as a good tool to prepare children going into the adult world. So over to you, Anna, and then it will be followed by Professor Adame.
Anna, are you still there? We'll start off with Professor Adame, just being mindful of time because it's available. Thank you.
Well, the topic of transition is also a topic that is different from different continents, depending on the level of socioeconomic development and also the structure of the health system. So for example, in many African countries, adult care begins at the age of 13 or 14. So these adolescents are transitioning to a system of adult care when they are not really ready to be independent. The adult system treats them as people who need to be independent and be able to take decisions for themselves. Whereas in many high-income countries, the age of transition is usually around 18 years of age, 17 to 19 years of age. So that also poses problems. But in countries that don't have the resources, and I see somebody has posed the question, how do you do transition in a low-income country? I think the challenge will be families actually seeking all the information they need. The era when the physician or the doctor just told you what to do and didn't explain anything is past. And even in places like Africa, patients are being more empowered to get to know the reason for decision-making, to be involved in the decision-making, to be the ones directing their own care. If that is done with the support of the families, even if you don't have a system in place like what Anna has in her hospital, you realize that the child, by the time they are adolescents, have become knowledgeable about their disease. They understand what their blood counts mean. They know who to call and where to go. And it's that kind of ability to navigate the health system that will help people in low-income countries to be able to have an effective transition program. And also where to seek quality care. There is evidence in Africa that people would travel further if they know that the quality of care they will receive will be much better. Evidence have shown that pregnant women in Uganda will travel 5 times the distance and not use the local services if they think it's a poor service. So the quality of care and where to find it is also something that as pediatric patients, they may use that opportunity to identify where they want to go and seek care. And then finally, a point for Anna, I think it's an a really good system you've started in your hospital. In Toronto, one area in which we have seen great improvement in our transition programming is to organize what we call transition clinics, where the adult care providers come to the pediatric site and together with the pediatric team sees the patient and their family. And then we have a navigator that interacts with the patient for up to a year during their transition to adult care. This to ensure that there's sustained effort to ensure that the transition is smooth and successful. Thank you.
Thank you, Professor Adami. Anna, did you want to add anything just before we go into the next topic?
Yeah, sure. I think something that I didn't mention, and I think is just another way to highlight that the importance of having a really good transition program, or at least communication, is that, you know, some of the research does suggest that, you know, the health outcomes can decline after children or young people transition into adult care, and that's, you know, if they haven't been equipped with the right education or the, you know, necessary tools for asking for help and knowing where to get help, and they might just either feel lost in a system that's very overwhelming, where they've had a parent to help them through all their appointments, and then they're sort of sent off into the adult world, and it's really hard to know what to do, and you can feel a bit lost, or you might just want to get to that age and be a bit rebellious and not go to your appointments or take your medication. So I think what Professor Adami was saying about having someone that will continue to follow them up through that transition process, you know, throughout a year would be really great to have as well, just to follow up and make sure, you know, they know where they're going and they know where their appointments are, and just to make sure that that transition, you know, we don't just cut the ties once you leave the children's hospital, that you followed through. I think that would be really beneficial as well.
I agree, and I think what I've seen and what I've read, and you know, the good transitioning would be for you to actually, my opinion would be maybe even a year after they transition that you follow up, because what I've read from the people that transition, especially in other countries, not so much Australia, in places like America, the care becomes so different once you are a child, and if you go into an adult hospital, you're literally looked upon like somebody who's as an expert. They consider you like an expert. The care is so different, and just the way they are treated. And I feel maybe there should be some form of continuation, maybe even in the first year, and not limit it so much. And also with the different cultures, you know, I know here in Australia, they're big on, you know, you're 18, you're an adult, your parents won't have anything to say. You know, our caregivers, we know our kids, and if they can be just, you know, that treatment, different cultures and different backgrounds, if you know, clinicians can sort of put that in place as well, where you sort of help the 18-year-old, they're not adults fully yet, and just to throw them into the, you know, the adult world. I feel, you know, continuation also, maybe another year, maybe, I don't know, but I feel most of the people have said the treatment is so different. And Yemi, I saw you shaking your head. What have you experienced when you left the kids to the adult world? What was your experience in terms of transitioning?
I mean, it's very true. I fought going to adult care for as long as I could, because it's almost like you said, and like it's been mentioned, they just throw us, kind of like throw us to the wolves. Okay, you're 18 now, you're on your own, do this by yourself. And as a sickle cell patient, you know, I came from a very good pediatric team, and, you know, they cater to us. They're like my extended family. I'm 45 a couple of weeks ago, and I still talk to my pediatric care team, you know, and I can't say the same for my adult care team, because the pediatric care team, you know, they keep us in a bubble. And so when we transition to adult care, it's like we're thrown, okay, go do this on your own. And, you know, I didn't know which way to go. And so it's something that I fought for as long as I could. But you have to go. They're not going to allow a 24-year-old, 25-year-old to stay under pediatric care. You know, they want you to take the steps and become the adult that they believe we are. And so it was a difficult process for me because I don't have anyone holding my hand as an adult. You know, as an adult patient, I have to identify the symptoms. I mean, it's like I'm doing it by myself almost. And I always was to a degree, but you know, in pediatrics, they shelter you in an awesome way. And adult transition, it's like, okay, if you call to schedule your appointment, good for you. If you don't call to schedule your appointment, too bad, so sad. You know, if you come into the hospital, good. If you don't come in, we're not going to follow up with you. That's your business. If you get sick, we'll see you in the hospital. So it's almost like hands off. And again, like Professor Odame said, it depends on where you are. So your location really, you know, where you are where you are located has so much to do with what treatment you get and what facilities are around and what clinics are around and what services are around. But adult care transition was very difficult. And I've heard the same thing too across the board, that is a very difficult process, especially here in the US, depending on your state, depending on your location again. And it's like, okay, you're on your own. And it was a very difficult process to get through.
We have Dr. Chira, who's sitting in for Dr. Chunda after she left. Dr. Chira, if you can hear us, what do you reckon would it take to start something like this in Zambia? And is it possible to have like a dedicated team and transitioning, and just where you are in terms of the Zambian system, if you can hear us?
Good afternoon, everyone.
Good afternoon.
I'd like to thank you very much for affording me this opportunity. So to discuss a bit about the Zambian scenario, in particular, University Teaching Hospital, we are in the process of trying to set up a dedicated adult care facility for sickle cell. And this has been documented in the recently launched sickle cell guidelines. Now, for this to be fully implemented, I think there are certain key things that need to be put in place. The first one being I think we need is a transition policy, which will guide us in how we're going to operationalize the transition from pediatric care to adult care. Secondly, we need to have a tracking and monitoring tool to help us track how many patients we have transitioned from the pediatric care to the adult care, and how are they progressing in terms of management of their condition. And then thirdly, for the children that are still under pediatric care, we need to assess their readiness for transition, because it's not easy for children who are being cared by the pediatricians to suddenly be transitioned to the adult side. So it must be an ongoing process. We need to have a dedicated team to assess how ready is this child to be transitioned to the. And then fourthly, we need to plan in such a way that we have a dedicated unit specifically for patients with sickle cell on the adult side. Currently at the moment, I'll speak on behalf of UTH. At UTH, we have a dedicated unit on the pediatric side, but do not have a dedicated ward on the adult side. So when patients are transitioned to the adult side, they find it difficult to actually settle because we do not have a dedicated ward for sickle cell warriors. Yes, so I think these are some of the things that we need to put in place to ensure that we have a successful program of transitioning our warriors from the pediatric side to the adult side.
Thank you very much. So Sophia, what has been your experience? How do you think you transitioned from, well, have you been in South Australia all the time, and how has been your experience?
Thank you, Aggie. Well, I was originally born in England, so my experience was different in respect that we transitioned here when I was about 10 to 11. So I was managed by a pediatric team during that time. And I'd say that my transition at the age of 18 to an adult hospital was difficult. I think something we all have to remember is children at 18 are still children, and our brain continues to develop into our mid-20s. So change is difficult for the average person, but it's even more difficult for a child. And the one memory that speaks to me, thinking back to my time, because it was a while ago now, is the day that my nurse, who was my pediatric nurse at the time, she held my hand to the new hospital, and she greeted me and, helped introduce me and acclimatize me to the new hospital. And I think that was a really paramount moment, and obviously something that has become a lot more advanced, especially as Anna was talking about the transitionary period that occurs in the hospital in Melbourne, and just how elaborate it is now. I wish that I had had that back so many years ago, but just having that support person there was really helpful in allowing me not to be nervous and be afraid of the new team and the new procedures that awaited me, because obviously a lot changed. And I think, just having that empathy there and that support, and knowing that you weren't being thrown into this brand new environment where you don't know your doctors or your nurses, is actually really crucial to ensure that you're meeting that whole of systems approach when it comes to a person, and not just targeting their physical support, but also targeting how they feel emotionally and psychosocially. Thank you.
Okay. Thank you, Sophia. Mrs. Mwansa, are you there?
Yes, I am. Yes, I was just trying to find out from Dr. Chirwa the experience that he's had in the clinical space at UTH. Has they found problems of transition, or what could be done before this transition policy is in place? The low-hanging fruits. How can we utilize this space, to call it the transitional place where we can really engage, the young warriors who are transitioning into adult life? Dr. Chiro.
Thank you very much, Mrs. Mwansa, for that question. So at the moment, we are trying actually to learn from the HIV program how they have transitioned their pediatric patients to adult care. So in our practice, we do start from an early age, talking to the patients on transitioning to the adult side. And not only that, in our clinic 4 that we have every Friday, it is a joint clinic for adults and children. So that helps us interact with the adult physicians and to prepare our patients to transition to the adult side. I must say, this is just something that we are beginning to do, but in the long term, we will need a dedicated team to actually help us transition our pediatric patients to the adult care. And not only that, on the adult care, we will need a dedicated ward for our sickle cell patients. At the moment, some of our patients that are transitioned to the adult side end up coming back to the pediatric side because they feel that they've been abandoned, the care is different, and so they want to continue experiencing the care that we give to our warriors in the pediatric side of the hospital. So I think it's something that we really need to plan adequately and ensure that once it's implemented, it is implemented successfully.
If I may comment a little bit on that. I think one advantage that many centers in Africa have is that they do not have standalone pediatric hospitals. That they are usually one big teaching hospital where both the pediatric and adult practice is on the same site. The challenges in many high-income countries is that you have a standalone pediatric hospital and you have a standalone adult hospital. And transition actually means a distance of travel with new hospital systems, everything different, even the computer systems don't talk to each other sometimes. So the advantage they have in Africa generally is that it is even possible to join the clinics together, so that the staff and the providers know each other. They interact all the time, and the transition becomes more seamless in a way because the teams work together. So that the Chewa, one advantage you have there is that you're already interacting with your adult colleagues in the same space, in the same hospital. So this should be a big boost to actually putting in place a seamless transition program.
I was just about to ask Professor Odami, it might seem, possible, but what you said before was that these resources, depending on which country you are, with the less resources countries, what can it take? What can we do in terms of other African countries? How can we change this and see whether it can work everywhere? Because it's something that's not very common in other African countries. It's very common in the developed countries like here in Canada, and America, but on paper, and it's also got advantages and disadvantages. We've heard from Yemi, who's in America, by the way, if she didn't, I think she said that at the beginning. The system is there, but also there's other disadvantages of how they're just thrown into the system because, they feel they're adult enough. But also on the other hand, we've got African countries where most, as you said, most hospitals or centers within the pediatric place, but we don't seem to have Tachira, they don't even have a policy yet. So how can we ensure that we have these services, across all settings, if we can say that?
Yeah, so when you live in a country with limited resources, you've got to be smart and very opportunistic. So for the Tachewa, it will be difficult to ask for new resources because there are many competing priorities within the health systems, and the health budget is limited. So you take advantage of opportunities you already have that will not cost too much if the pediatric team and the adult team figure out that for those who are in the watershed age, maybe we can all see them together and so create a kind of a virtual transition system without even calling it that, because all you want is to empower the patient and their families to be able to navigate the adult system. One other point I want to make is that globally, sickle cell has more been a pediatric disease because for many years, survival of patients with sickle cell disease was limited. So what we are seeing is the price of our success. So with our success, more children are living to become adults. And what adult providers have realized that they haven't really made sickle cell an entity, an area of interest that adult physicians can make a good career out of. So in places like America and Canada, we are now promoting more adults to get adult providers to get interested in sickle cell disease. It was the same with cystic fibrosis. Cystic fibrosis was primarily a pediatric disease. Now people with cystic fibrosis are living to become adults. And suddenly in all our systems, we realize that we don't have the adult expertise and the interest to care for these people. So I am empowering sickle cell warriors to really articulate that to their governments, that you didn't pay attention to us before. Because if you go to Africa and you go to clinics, most of the patients are younger children. And the reason is simple. They are not living long. But once you start good treatment, pediatric care, what you're going to see is that it's very easy to prevent mortality, very easy to ensure that people have survival beyond childhood into adulthood. So warriors need to let their policymakers know that you can't ignore this problem. This problem is going to grow. you're going to see more and more professionals, adults who are contributing to society, who live with sickle cell and who deserve good quality care so that they can continue being good contributors to society. And once we begin to articulate that way, they'll realize that it's not just pediatrics. You need to create adult care programs that are quality and that meet the needs of adults. And so all over the world, transition is an issue, but in places like Africa, it's an entirely new concept for certain diseases because those systems weren't used to seeing a lot of adults with the problem.
Yeah. I think that's a very good topic you've said there, Professor Odami. And, in terms of us and all this, in the sickle cell space and especially warriors to take it up upon ourselves to inform our leaders that, they shouldn't neglect the sickle cell disease. This is also what we are seeing in the developed countries because unfortunately, as we know, this disease affects people that come predominantly from certain places like Africa and Asia, and we've migrated to these places like, Canada and Australia. And, I feel government, they're still like folding their hands to wait and see what's going to happen. And, Nana will tell you 10 years ago, I think they didn't have not even, I don't know the numbers, but I think Dr. Anthea said, I think they've grown over maybe 50% or so. Anna can tell us the numbers. So until we start acting now, even in the developed countries, or else we are going to wait until it's not manageable. I think the time is now for developed countries to actually start, where are we going with this? But also for the African countries, as you said, it's high time that we held our leaders accountable, that they should do more because this is our issue. It's our issue, and as Africans, we should do more, and not just wait until it's a bit too late for others, unfortunately, who won't live past some age. I have Gautang in India. As a caregiver, what worries do you have for your kids in terms of transitioning and in terms of just access to care? Because now we are going into the next topic, being mindful of time. In terms of access to care and going on into adults, what's your take in India? What have you seen is working and what's not working?
Thank you, Agnes. Actually, in India, at the age of 13, a pediatric patient get transferred to the adult. So when my son now is 16, but when he was turned just 13 and was in a crisis, then he shifted to the adult ward directly. So before that 12 year, when he was pediatric, he used to say the doctors, he used to say the nurses, he was familiar to that staff. But when he shifted to the adult ward, he just looked at it's a new area, new doctors and staff are taking. So the main problem he was facing that he just fears, and he's when the doctor trying to put the intracate for fluid, so the nerves they didn't catch. After 10 pricks, 12 pricks, sometimes it takes 2 days to prick the intracate. So doctor has to call the pediatrician. Then pediatrician come and the manage the ways. It's a simple things which I face. So I would like to say that the patient should not be directly transferred after 13. It should be at least 15 or 16. Or otherwise, the transition period should be managed by the hospital by the friendly atmosphere. In our India, mostly pediatrician tackle the sickle cell patient in private hospital till the 16 or 17 age, because the pediatrician has the habit to go there. They don't want to go to another doctor. They assume that he is the only doctor to treat his well. So this problem is very common here. So I would like to say that after 13, the transition period should be very smart, should be very polite, and all the we know that there is a issues of adult is different, and the issues of pediatricians are different, just like a necrosis, and just like also a social stigma is also comes in the mind of the patient because he just grown up. And also here we are saying that the orthopedic problem just like a necrosis. So we know that the adult problem is different, pediatrician problem in different, but the between the time adolescence and the adult, it should be tackled by smartly, so that the patient will manage that period. Otherwise it goes to very harmfully, so it impacts to the mind of that patient. So I used to see that 2 to 3 years with my son also, and also with all the patient who were admitted in the hospital at that time. So transition is very important, but it should be very precaution by taking very precaution, I think. Thank you, Agnes.
Thank you so much for that experience that we just shared. Very quickly, before we go to our next topic, we just want to hear from Natasha and Musonda, their experience on their transition into the adulthood. Natasha, we start with Natasha. Natasha, are you?
For me, yes, I'm here. For me, the transition was very strange because my pediatric years I actually grew up in South Africa, and then I transitioned to my adulthood when I moved back to Zambia. So changing doctors altogether and changing countries, it was something really huge, getting used to how things are done here. I would say for me, I think my knowledge became less and less because after my pediatric years, I think I started experiencing less crises. So yeah, it was very painful. Like someone else spoke earlier, they said they still speak to their pediatric doctors. I still do that as well. I feel like we're really, really connected, like we're one family because we're together for so long. So yeah.
I think we are now coming into our last topic. We're just being mindful. We've got experts on this panel that I'm sure I've got, and everybody else have got other things to do. This topic wasn't discussed last week. We just wanted to find out, summing up all these, how does it affect the sickle cell warriors and their families and everybody else in the sickle cell space in terms of access to care and the mental health that goes around not having the best care for everyone else. I'll bring in Professor Odami. What do you think this topic will contribute to getting that proper care for people living with sickle cell disease? Thank you.
Yeah, thank you for that question. I think there's no doubt that the way we should look at sickle cell care is as comprehensive care. That requires a multidisciplinary team. It's not just a physician and a nurse. You need a psychologist, you need a psychiatrist, you need an access to all hosts of specialists that will come in to support the patient. And so we should begin looking at it as comprehensive care and not just having maybe a physician and a nurse in the clinic, a doctor who looks after sickle cell from the sort of physical point of view, because the psychosocial impact of sickle cell disease is probably sometimes worse than the pain. Indeed, nearly 30% of sickle cell patients don't see pain as a problem. So there are sickle cell patients who hardly get pain. And so for them, this whole pain issue doesn't resonate as much. Nevertheless, they may have fatigue. In fact, in a research done in the United States of over 5,000 adult patients with sickle cell anemia, when they were asked to rate what was their most important issue of concern, We were shocked that it wasn't pain as number one. Number one was fatigue. And that's what the anemia does. You wake up, you don't have the energy, you don't have the drive, you seem to get low, and the low anemia and the state of perpetual fatigue actually leads to depression. It leads to many other things. It affects relationships. It affects interaction with your social environment. And that is what is weighing on sickle cell patients a lot. And they need a space where they can articulate all these concerns and also see that their concerns are being met. So an ideal sickle cell practice should be very comprehensive. And you should have orthopedic surgeons who love patients with sickle cell. They focus on sickle cell patients, or they like treating patients with sickle cell. General surgeons. One thing that I've always seen, that just because you have sickle cell doesn't mean every symptom you have is sickle cell related. I've seen patients go in with an appendicitis, and people would think they have an abdomen crisis because they have sickle cell. Whereas what they had was appendicitis, which every person is susceptible to. So you need a system that recognizes that sickle cell patients are not defined by just their sickle cell. They can have other conditions as well. They can have depression, they can have SLE, they can have rheumatoid arthritis as well. They can have other conditions that the normal population is susceptible to. This has always led to late diagnosis because everything is being attributed to the sickle cell that they have. So we have to look at sickle cell patients, not defined by just their sickle cell, but as people, holistic people that have various facets of their lives, and that will probably need attention when they determine that they need it. And finally, I will say that this can only be resolved if we look at it as patient-centered care, that the care is delivered to meet the needs of the patient. And who defines the needs is not us, the providers, is the patient who defines their needs. And we should be listening to patients, looking at their needs and helping them find solutions to them. So they should be guiding their own care, and they should be having the final decisions on all clinical matters that relate to them. So this is what I would say is a challenge ahead, that we often are only addressing one or two components of the disease, whereas sickle cell disease is a multi-system disease. It's interesting, it's a one mutation in a hemoglobin protein, but its impact is on virtually every organ, including the brain, including memory, including the way you feel, the fatigue, the depression, the tiredness, and then all the social impact that that has. So I think that's the way we need to do it. And warriors have to be heard. And if you're a warrior on this discussion, I'm empowering you not to be silenced. Let them hear, even if they are not addressing, keep talking about it, keep banging, keep talking about it. Because unless you tell people what you need, they are not going to address it. And so feel empowered, tell your doctors, tell your systems that this is not good enough. I'm still not feeling well. I am disappointed about the care, or I'm feeling depressed. I need help. Talk about it, because that's the only way we can improve the system to address your needs.
That's well said. That's well said. Yeah. Mrs. Mansa.
Yes, yeah, that's so great, because when we were throwing these questions on the platforms that we are in my country, a lot of issues came up, and they were just directing to what Professor you just mentioned, whereby if there was a dedicated place, there was database, all these things that we're discussing, we can have a specialized place where we can have monthly meetings, where we're able to share the experiences and the things that we can gather that can be useful to others who haven't experienced it. Because as you were saying that, you know, from your research, that it did not actually tackle the pain, but it tackled other things which actually now bring about all these other ailments that warriors do experience. So if there was a dedicated place and a proper database that has been collected in terms of the way that we've been seeing these doctors, so they'll be able to write that this experience, so and so had experienced it and what happened, you know, so that they would be able to figure out, and all these challenges that are being faced, you know, can be lessened. So this dedicated place and database is really something that we need to speak about. And I'm so happy that, you know, just having, you know, like for me from Zambia, just having Dr. Chirwa and Dr. Chunda has really made me happy, because then we've got a space where to start from. And we've got Dr. Musonda there, Natasha, who are Zambians, and they're, you know, they're enlightened. They would be able to speak about these issues, and then the doctors would know how to move from there. So this is such a perfect platform that we can come out from here and be stronger, and our voices can be heard in the way that we are dealing with this thing. So I think if Dr. Mwilwa is not here, we can move to the next topic, isn't it, Agnes?
I think we are almost at the end of the topic. I think we need to give chance just to Anna summarize. I know in Australia we might say we are lucky that we have dedicated support. We have most of the access to care, but also we have got challenges, Anna, as you know, in terms of medications. Right now, we only have hydroxyurea in Australia. Like most countries in Africa, we don't have any other drug. And of course, this comes down to, I guess, the numbers, as we said. But what's your take in terms of just the holistic care for people affected by sickle cell disease in Australia? Because I know the struggle for hydroxyurea, that's something that we've gone even to the manufacturers of the drug to ask for, you know, other things like other doses. And there's this, the red tape between the government can't do anything if the manufacturer can't accept to actually produce other doses. And then there's the other approvals, TGA approval. So we don't even have any other option. So if somebody, I know my friends, their kids, myself, my daughter, the hydroxyurea, and as you know, it stopped working. So we didn't have any other option. So what's your take in, you know, it might seem that, you know, we are here and everything is perfect, but as somebody who's actually looking after us, what's your take in terms of access to care for patients in Australia?
Yeah, I think, you know, comparatively to a lot of parts of the world, obviously we do have very good healthcare and support, but there's still areas that are lacking. And as Professor Adami said, it really is something that, you know, affects, that's one part of you know, your life. You have sickle cell disease, but then you can have any other complication just like anyone else. And so things we really do still lack in our healthcare service are sort of dedicated social work, which is really important, because I find myself trying to do a lot of that support, but I'm not trained to do that. I don't know all the avenues and all the ways to help. So that's something that we really do need to push for. We need more you know, pharmacy input, as you say. The medication, the hydroxyurea issue that we have is a challenge, you know, and it's costly for some people. We can't get the right doses. The availability isn't as easy as you might imagine that it would be somewhere in Australia. So, you know, well, I think, yeah, we do have a pretty good setup here. There's always ways to improve on, and I definitely think, you know, information sessions and talks like this, Agnes, really inspire me to even keep on going and working out ways that I can help improve for our population as well. So, yeah.
No, I would just like to say, like, you guys are just the best. I always say this is not the first time that I've spoken about. If they ask me, like, which country I feel, you know, you really do the best in terms of looking after us. I've told these people that I've got Dr. Anta Greenway's phone number. I used to call her even when I was in Zambia. I've got this problem 24/7. But we feel you are also, the system fails you. There are some things that you have got no control over. You know, you've got a fantastic team, but as we know, in terms of other medications and other just support systems in the Department of Health and them, there's things that are failing because you have got no control. But as a team yourselves, you guys are just the best. And, you know, I always say that, you know, we've got the best healthcare system. And, you know, my daughter had a bone marrow transplant. It was free, paid by the system, but that's not for everyone. And this is why we're doing this, that, you know, this condition affects a lot of people that come from less resource countries. And what are the government doing about it? Let's make sickle cell as a priority because it affects most of our people. And, you know, I think that's something that should be worked on. Dr. Chira, quickly, I know you're mindful of time. What can be improved before we close and give the last say to everyone on the panel? Thank you.
Thank you very much, Agnes. I think what we need to work on, one, we need to work on awareness. We need to raise awareness of sickle cell disease amongst the communities so that people get testing, especially for those that are not aware of the carrier status. Studies have shown in Zambia, particular, that the carrier rate is about 18%. So which translates roughly about 1 in every 5 adults. And so with that awareness, we need to comes in the issue of testing, so people should know their status. At the moment, we are in the process of introducing a newborn screening at Arthur Davison Children's Hospital, and we also roll it out at the University Teaching Hospital. This again will help us identify children at an early age, those that have sickle cell, and thereby put them on treatment. So PNV prophylaxis, anti-malaria prophylaxis, folic acid, and we continue to monitor their growth and well-being. That way we will reduce the morbidity and mortality associated with sickle cell disease. Not only that, we need to also increase awareness amongst physicians so that we have this awareness about the disease and how to manage it. Recently, we launched the first ever sickle cell guidelines for our country, and we hope to roll this out to all parts of the country so that healthcare workers in the country are aware about sickle cell and how to manage children with sickle cell. In addition, we need to improve the availability of drugs for our patients. So drugs such as folic acid, PNV, hydroxyurea. Particular hydroxyurea is very important for our sickle cell warriors. So I think these are some of the things that we need to work on for our sickle cell warriors. Thank you.
Okay. Thank you, Dr. Chira. Mrs. Mwansa.
Yes, I just wanted to appeal to Dr. Chira that a lot of us are ready to help with whatever we can to make this awareness a success here in Zambia. And you can take up the initiative and just engage us and just whatever you want to come out or whatever it is. If we have to start with just a small place where we can have dedicated talks at UTH instead of a clinic, but just a deliberate one where we can start from, like what Professor was saying, that you can start with the resources that you have. Probably you can just create a small place, calling it transition and awareness talks and just sharing best practice in sickle cell management with the caregivers and the warriors, where we can dedicate ourselves to come just and share and build up from there. It is very exciting, to hear to you speak and being able to find this time to come here. We really do appreciate and learning from the experts like from Anna in Australia. I think this is what we need to be hearing about and comparing notes and seeing how best can we help our third world in this case. And just it also when they see some successes in Zambia, we can see some in Nigeria, in Ghana, in Uganda, because all these topics that we've had, it's like you get even overwhelmed on how you think that people have lived with this, for such a long time, and you see even that just making a bandage on the leg, it's something that we need to know. And having participated in this, I know, okay, how can you prevent the sores? How can you, even simple things that we think, useful or not useful, but we have no access to them. It really leaves a lot to be desired. And these challenges, as we heard from Anna's presentation, there are things that we can do, starting with databases and just following up on things that we're able to do from the resources that we have. When I was doing this small research on the medicine, that helps. What is the name of the medicine? hydroxyurea.
Hydroxyurea.
A dose of 10 tablets is 105 kwacha. And you've got, crises every month, every other month. I mean, it's just something that is impossible to get. So we can just start with that. How can government, help with making available these medicines? And I'm so happy that there's a policy in place where we can actually start from. And I personally will be following up. I'm lucky that my son is not so much in crisis, anymore because of the care and also the family, the family awareness of what he must do and what he cannot do. So if we can share these experiences and the medication is there when you need them, then it's really going to help us. Yeah, that's what I really wanted to thank you, Dr. Chira, for being able to actually share this, and also to Dr. Musonda and Natasha, the team that is coming from Zambia. And just to say, Agnes, this is fantastic. And I know that we can do so much if we just stick together. So many associations who everyone is doing a small thing, we can come together and do a big thing that we can start, seeing the results coming through. Yeah,
thank you so much.
Yes.
Thank you so much, Mrs. Mwansa. We are, did somebody want to come in?
Something? Yes.
Yeah.
Thank you very much, Mrs. Mwanza. And also, I think we should not just focus on UTH. This is something that we can do countrywide. And we can take advantage of various platforms such as TV and radio programs to help increase awareness of sickle cell in the country. Thank you.
Yes,
okay, thank you. I think we are just about to wrap up. I'll give Sophia, talking about our experience in terms of access to care and giving a last word, because I'm mindful we're running out of time. Yes, quickly, Sophia, and then we will go and just do our last talk before we finish. Thank you.
Thank you, Agnes. And I just wanted to say thank you to everyone that's joined tonight. I really liked what Professor Dami said about the access to care and how it has to be a person-centered and patient-centered approach. I think that's something that is so important. Sickle cell disease touches us in so many different ways, and so many individuals are affected by it differently. And so the way you target each person's experience is going to be different depending on who you speak with. So I think the psychological effects of sickle cell disease can have a huge impact on, a person even just turning up to their appointment. So knowing that they have that access to care there is so imperative in them getting the help that they need and continuing to be compliant with taking medications, staying compliant with going to their appointments, and living the best life they can, and living to a long age. And it's not just about existing, it's also about prospering in your life. So I think having a really good team that will work aside you can help support you in living the best life you can have. Thank you.
Thank you so much. Natasha, do you want to just your last word also, and your access to care before we go to Yemi?
Yes. Firstly, thank you, Team ASCA, for always giving us the platform to talk about our experiences. And this is really, really great, having to connect with people from around the world and hear different experiences. And it's really, really amazing. And Mrs. Mwansa, I agree with you. I think it's really important as a community to just come up with a monthly checkup, basically, to talk about the things that affect us the most, because most of the time, the thing that I've seen is that so many people come to me asking for advice, even on things that I don't even understand. So when we have a group of so many people with different expertise that can come together and help out, I think it's really, really good. And thank you all for sharing, and I'm really happy to learn from all of you.
Thank you, Natasha. Yemi, do you want just to give your experience and your last word? Thank you. You're mute, my darling.
I was saying thank you so much for the opportunity to be part of this group, part of this forum. It's been a privilege, just being able to share, but more than that, to learn so much. So I'm grateful for the opportunity. I'm grateful to have spoken, learned, and discussed with all of you. Access to care is very important, as we all know. It's been said over and over. And I just hope it's something that you know, each one of us in our own little areas and our own little arenas can help to instill, can help to initiate, can help to develop, maintain, and sustain. It's something that we as sickle cell patients, and even the family of sickle cell patients, is very important for us just to have that access, that support system. So I hope over the next, you know, months, years, is something that we're definitely able to say, okay, this is what our voices have been able to do. Thank you so much.
Thank you. Thank you so much, Yemi. Gautam, do you want your last word? And yeah, quickly before we finish. Thank you.
Thank you, Agnes. Access to treatment and care is a very big problem in India. Actually, as I said, that India is a country of a country. India having actually 28 states, and every state's population is very big. For example, your Australia's population is 2.5 million, 25 million actually, and our smallest state called Chhattisgarh, its population is 32 million. So we have India is a country of 28 states of the states. So it is very difficult to maintain the quality care and access of the treatment. And as I early said that the 66% of part is the rural area, and unfortunately sickle cell disease comes in a rural area. So occur in a rural area. So it is very difficult to access. And the second thing, the quality of life is not improving. Exactly hydroxyurea we are taking, but it seems that it is also not sufficient because it's not improving the quality of life. Because my son is taking hydroxyurea since last 7 years, but he's always pain crisis comes after 2 months and 2.5 months, 1 month. So it is not getting so much quality of life. So I mean to say that apart from hydroxyurea, there should be some investigation so that those patients who can't tolerate the hydroxyurea, those patients who is not responding the hydroxyurea, what's option for that patient? So it is very huge problem. So access of treatment and care and quality of life, it's a very huge issue. It should be short out, and the government of India is doing for this in the right direction now. So we are hopeful that it will be very soonly sorted out. Thank you very much, Agnes.
Thank you. Professor Odami, your last word before we finish. Thank you.
What Gautam has just said has touched me so much. Agnes, please connect me to him, because I think your son, is it your son or your daughter, can benefit better from hydroxyurea. So let me make a statement about hydroxyurea. Studies has been done in Africa to show that the dose matters.
Oh.
The dose matters. That if you don't give adequate doses to some children, you're not going to get the outcomes that you need. And many doctors, many providers just prescribe one dose, and they don't follow up to see whether the dose, and this is where medicine should become individualized, so that because some people metabolize the drug differently and they need more to achieve the impact, the one size fits all is no longer accepted in medicine in treating a chronic disease. And so I would like to interact with you to see if I can be more helpful to your son.
Yes, sir.
But I mean, I think this is very good. And for my African partners, I think because your experience will more mirror the experience in Uganda or Ghana or Nigeria, I will recommend that you form partnerships with other groups within your neighborhood. For those in Zambia, I think you have the East African Economic Union. I think if all those countries together form a united front, you can take it up your political systems to see whether within that regional zone that programs will be supported in a way that makes the system better. Because this is about systems issues, and I worry about families that live in rural areas that are nowhere near metropolitan cities, and don't have access to any of this at all. They are being neglected. They don't have any access to care. For care to be accessible, it has to be available, it has to be affordable, and it has to be quality. And there are various aspects of quality. It should be safe, it should be effective, it should be patient-centered, it should be timely, it should be efficiently delivered, and above all, it should be equitable. We can't talk about equitable care in Africa at all. If you are poor or if you are in a minority ethnic group, you have no access to this at all. And these are the things that we face. So thanks for all these opportunities. There's a lot of work to do. And I'm happy that warriors and parents are on this platform and that you are devoting time to make the situation better. But let me give you a word of hope. Sickle cell is in a better place than 10 years ago. Believe you me, it's in a better place. Everywhere I go, there's now an understanding and a perception. Even the pharmaceutical industry is now beginning to realize that sickle cell needs a lot of attention. More and more drugs will be available, and cure is going to be more available to many more families. So thank you for this opportunity, and let's do this with hope and not pessimism.
Well said, Professor Odami. I think I want to touch on the question of having these consortiums or networks. I feel it's also an African Union issue, Professor Odami. I don't know what you think, because if we say let's make this group in the East and in the West, I think we should just form one African something to take this up to the African Union and say, this is your issue and we should do something about it, but it starts with us in our respective countries, and then let's all link up and do something about it. So I'm just, thankful that we are doing this, but who haven't I given the last talk? Is it Mrs. Mwansa?
Yes, but before I just go to my last topic, what Professor has said really has resonated to what happens in real life, where medication is like, oh, this one, we gave this one this kind of dose and it helps them. So you're actually pretending that you're still in pain. So these are the issues, a lot of warriors have been labeled to be like addicted to certain kinds of medication. I think it should be individualized so that everyone is able to benefit from the breakthroughs of medication. And that is what I've gotten from Professor. So my last words really are very, very simple, and just requesting for those powers that may be able to make this happen, that let us have this dedicated hospital, ward, pharmacy, create a database. Yes? Are you able to hear me?
Yes, we are back now. Yes.
Now, I'm just saying that let us have this, the dedicated hospital, ward or pharmacy, because we have different kinds of even disability arising from sickle cell disease. So if we have this dedicated place or pharmacy, we'll be able to, warriors will be able to benefit greatly. And if we also have create a database that will be able to give the doctors, the nurses, the warriors, and the caregivers the information they need to take care of the sickle cell disease effectively and efficiently. Because sickle cell disease is a lifelong challenge. It's not a one-off that I'm going to get well. It's a lifelong. So what can we deal with properly? And we have to feel safe in the places that we go to. Caregivers sometimes leave the hospital and do not, they do not have to do this, all these chores and, cares from wherever they are coming from. So it is very, very important that whether it's at home or at one point in life, we all must give each other effective ways of dealing with sickle cell disease and all the other diseases that come, not just because you're a warrior or you're a caregiver. Even while in hospital, the caregiver gets sick of malaria, they have to leave the patient, and if people are not aware of what's going on, then we will miss, all these efforts that we're trying to do. So that's my closing remarks. That let's do what we must do as we, prepare to go to the African Union with sorting out this problem.
Well said, well said. So people, participants will be promoting you now like our tradition, but I just want to thank you everyone. This has been very insightful. And for us, I think the reason why we did this is not just about talk. I think we want to come back next year and say what has happened. Professor Odami, you'll be receiving a report from all these, all these talks and other clinicians and other government officials to say, talk is talk, but we need action. We need to see that things are improving for the sickle cell warriors. Things are improving in terms of medication, in terms of dedicated supports, access to care, everything that we are talking about. Psychological effects like last week, newborn screening, all these topics that we have until we finish off. So we are doing these sessions because they came on just from encouragement from the people that came on what we are calling, Sickle Cell Talks with Me, because we just wanted to play a part because of the COVID. That's how it started. And we thought, we can open this platform to people that, want to just say anything about sickle cell, but also to our brothers and sisters from the African countries where sometimes it's not easy to have like a Zoom session this long because of course, in terms of resources. So we'll talk, but we want to see action. Where are we going to go from here and what is going to happen about, I'm glad we got Dr. Chira and we had, Dr. Chunda, Professor Odami, you are from Ghana, we can go and see what's happening in Ghana, Gautam in India, and we have Nigerians, we have Gambians, Cameroonians, so many people that are in the group. We have over 40 of us. We want to say action, and it's not coming from me, from a caregiver's point of view. We have most of the people on the platform are all warriors. We had about 26 questions. We had to narrow them down because we are not going to do this for the next 2 years. So, talk is talk. We need to see action. And that's why we have dedicated people in this group to say we want action. And hopefully with people like your influence, Professor Odami, Dr. Chira, Dr. Chunda, and everybody else who's come on this group, if we take our cries to the policymakers, hopefully that will help us. Anna, can I just give you your last word before we go? Thank you.
Thanks, Agnes. Yes, I've really enjoyed listening to everyone, and I think it just helps to motivate, to keep me inspired, to keep being an advocate, to keep doing the best I can for our patients with sickle cell disease and their families. And it's it's just a really insightful way to see other perspectives from the patient perspective, from families, from other caregivers around the world. So thanks for the opportunity.
Thank you so much. I think I'll give Professor Dr. Chira your last word as well, as we promote people to come on the screen. And if you've got anything to say before we wrap up. Thank you so much, Dr. Chira.
I'd like to just say thank you very much, Agnes, for giving me this opportunity to be part of the panelists. And I'm also truly grateful from Professor Odema for the wise words and the excellent points that is brought out. I think this will help us manage our sickle cell warriors better. And also, it's also given me an opportunity to see how the warriors are affected in terms of how we transition them from the pediatric to the adult care. So I think this talk is a very important talk. This is something that we need to continue talking about. But as you've mentioned earlier, we need action. We need action in terms of ensuring that certain things are put in place, drugs are available, physicians are available, and we have the infrastructure and funding for our sickle cell warriors. Otherwise, I'm truly grateful, and I'm looking forward to being part of more discussions on this platform. Thank you very much.
Thank you so much. So I have a big team of us. Everybody has joined us now. If you've got anything to say, we've got professionals here who will be leaving soon. Please say something, or else we'll be getting a family photo and we'll be leaving. Thank you so much to everyone. And even if you're not part of the 40 plus people on the group, for joining us. We are coming back again next week with another topic, and next week's topic is
Agnes, can I come in? Agnes, can I come in a minute?
Who's that? Sorry. Just say your name
Dr.
and where you are.
Dr. Wafula, Nairobi.
Oh, yes, please, go ahead, Dr. Wafula.
Agnes, thank you very much for giving me a chance. And I just want you to pass over my greetings to Professor Dame, tell him we last met in Tanzania, I think 2014. I have enjoyed the talk. I just wanted to mention
We can't
one word
see you.
about.
Sorry. Can you just put your camera better so that? Oh, there you go. Yeah.
Yeah, can
better.
you see me there?
Yes.
Thank you, Agnes, once again. I just want to thank all the panelists that have been on this afternoon. Excellent job. Pass over my greetings to Professor Dame that we last met in Tanzania 2014. And I just wanted to congratulate Dr. Kirwa in Zambia, and also to tell him that we'll be launching our own sickle cell guidelines in Kenya very soon. We also didn't have. And for Professor Dame, I just want to remind him that he had promised us at one time he will visit us down in Kenya, and he's welcome.
There you go, Dr. Shira, Professor Odani.
The other one is the caregiver in India. In India, they use what we call a fixed dose of hydroxyurea. So if they pick a dose of about 20 per kilo, that's where they keep it. So as Professor Dame said, he needs to go back to his doctor because hydroxyurea is a good drug. The more you use, the more advantages the patient gets. The only problem is that it's also a drug that suppresses the activity of the bone marrow. So you've got to balance. When you use it, you look at the effect it has on the bone marrow, and then also look at the benefits the patient is getting. So what the doctors in India needs to do for his son is to now what we call to escalate the dose. And normally you go up to about, maximum you can go is about 35 milligrams per kilo, but that depends on how the bone marrow is functioning. But the father is going to see that as they escalate the dose, because the dose is individualized. Some you can escalate up to 35 and then it starts getting an effect on the bone marrow. But some of them, the effect on the bone marrow that is dose limiting may start at a dose, say, of about 25 per kilo or 30 per kilo. So he needs to go back like tomorrow and have a word with the doctor that there's a concept called a maximum tolerated dose that can be used. And as they use that dose, normally you achieve that maximum between 6 months and 8 months of using hydroxyurea. So as they upgrade the dose, they also check on the blood parameters to make sure that they are not affecting the bone marrow to an extent where they will affect the patient. And with time, that young man is going to have a better quality of life. And the recent study in Kampala had to be stopped because of that. They compared a fixed dose like what they're using in India and the maximum tolerated dose, and the difference between the two groups was totally different. So the study had been brought to an end because of that. If you looked at the pain, the ones who are on a fixed dose were getting about 200 episodes, and those who are not, who are on a maximum tolerated dose were getting possibly 4 times less the amount of pain the patient has. So within a very short time, the caregiver in India should see a big difference. Now, if they're already using an MTD dose, then they can think of other drugs. And now there are 4 drugs that have been registered, including hydroxyurea, for modifying the course of sickle cell disease. The only problem is that the others are expensive, like for example, L-glutamine. L-glutamine is a good drug. The only problem that it's expensive and supposed to be given twice and doesn't have a big role in terms of pain episodes. But there's another one called Vexoleta. It's a beautiful drug. It also has an effect on painful episodes. So they can also look at all those alternatives. The last one I wanted to say is that unfortunately in many African countries, we still have what we call hematology clinics. These are clinics where everybody goes. You have the cancers, you have just the simple anemias. And this overcrowds the work of the doctors. And because of that, when a sickle cell patient who is simply coming for what we refer to as maintenance, I'm not sick, but I have to see my doctor to adjust my doses, to look at my blood parameters. When he goes to a clinic like that one, he finds that the clinic is already too loaded, and sometimes they walk away, especially the adults. But as Professor Dambe mentioned, initially we didn't have to care about the adults with sickle cell disease because we didn't have them. But as the numbers go by, we now have to have both clinics for the adults and for the children. And as Professor Dabe mentioned, the best clinics to run, especially in the African continent, in order for us, if we try to put the adults in their own clinic and the pediatrics in their own clinic, it's going to be expensive for us to be able to do that. So the best thing is to have one house where we can house both the adults and the children, and then bring in the specialists. For example, if you want a cardiologist, the clinic will be able to book for those. You'll be told you have a cardiac clinic on Tuesday, and therefore the cardiologist will be available. If you require to see an orthopedic clinic, the orthopedic clinic specialists will be invited to the same house. And I think using that, we should be able to give two things. One, that we have specialists brought, and two, the transition occurs, but occurs in an environment that is actually good to those who are there as children and also good for those who are adults. Because when we look at the mortality of sickle cell patients at the moment in many African countries, we are saving them as children, but we are losing them between 19 years when we transition them to they are possibly 35. Why? Because as soon as we transition them, there's just no care. I just want to thank you, Agnes, for bringing up this. You remember I had requested to talk about transition, and it's good that we mentioned that. I've learned quite a lot. Thank you.
And you are coming back for a dedicated talk, Dr. Ofula, so you're definitely coming back. We have a date for that. So I think we are coming to the end of our session. Thank you so much, Professor Odami. You've stayed up to the end. Dr. Chira, I'm not sure whether he's still available. Dr. Chunda, who joined us. We've got our panelists. Anna, you're still here. Natasha, Mrs. Mwansa, Gautang. I think Dr. Msonda dropped off. The internet was not too good. Sophia, and just thanking everybody who stayed on, and we are back next week. But before next week, actually, you know, this talk of treating the whole person is something that we talked about last week, and we felt we didn't actually exhaust the topic. So tomorrow we have another group that's coming to talk about mental health. I've got people from Nigeria. We have Msonda tomorrow again, Sharif from Uganda, Tim in Nigeria, America Tiona, Dr. Msonda, and we've got Anne Walsh in the UK, and we have a mental health expert. People still want to talk. As you can see, Professor Odami, please take this news to your colleagues that people are willing to put forward their frustrations and they want solutions, because most of us feel sickle cell has been neglected for so long, especially in less resource countries. And please take this word. And if anybody has anything to say, this is your chance. Otherwise, please put your cameras on and let's take a big, nice family photo before we leave. We do this all the time.
I just want to say thank you for having us all here on this amazing platform and just being inspiring as always. Thank you.
Thank you so much. Anybody else? Arafa, did you want to say something from Tanzania?
Yes, thank you so much. Thank you. That was really amazing. And I would like to tell Professor Odami, we also launched our first guidelines for treating and managing sickle cell in Tanzania. And we actually opened a joint clinic for cardiac and sickle cell on Wednesday. So we're doing good with sickle cell in Tanzania.
Okay. Thank you so much.
Yes.
So Chan, you put a lot of input in the chat box. So did you want to say something? You are mute.
I just wanted to thank you for this very important forum. I've learned a lot. I thought I knew everything about sickle cell because I was born with it and I'm living with it, and I just started creating awareness recently.
Where are you joining us from? Sorry. Where are you joining us from?
Nairobi.
Okay. Yes, please go ahead. Sorry.
I thought Ori just wants to create awareness or in other part of Africa. So I got in touch with the Children's Sickle Foundation and few others, and I'm involving creating awareness. And I think we need to verify not only creating awareness, but should take action and move to areas that focus on places where medication is a need.
Thank you so much, everyone. We are finishing off.
Thank you so much.
Yeah. Way past our finishing time. Professor Odami, again, thank you. Daniel, oh, there you are, Daniel. Daniel in the UK. One word before we go.
Okay, listen, well done, everybody. This is an amazing initiative. Agnes and I, we connected on LinkedIn and we met in London at ASCA. Dr. Odami was there. So this is an amazing platform. And I definitely like the African Union idea. I like to think that that is definitely a concept that we can push. So yeah, let's keep pushing. You know what Dr. Odami said, we have to just keep knocking on that door and refuse to go away. We just have to keep knocking, and then eventually somebody's going to get fed up with us and let us into that house. Okay,
and we are doing that until January 9th. January 9th, we are going to rest for a few months. We are going to regroup, get the reports, and then take action. And then we'll start it again and again and again. Professor Odami, please take all these to the experts. But that's it, family. We are back tomorrow for a mental health session. Next week we've got sorry, I forgot the topic. I wrote it somewhere. We have session 5. And session 5 next week, they have, I think, psychological. They've got social relationships in sickle cell disease. That's the next topic. So we have another panel next week. I'm not on the panel. We have another panel, social relationships in sickle cell disease. And so, yes, we are done for tonight. This was series 4. We are back for series 5. And we invite you again to join us next week. Thank you again, everyone who's managed to join us and to stay on.
The family picture.
Oh, family picture. Who hasn't put their cameras on? Family photo. Are we all smiling?
Yes.
Okay, Sophia, did you smile? Thank you so much, family. I think that's it.
Bye, everyone.
Thank you. Have a good one,
nice
everyone.
day. Thank you. Bye.
Thank you. Bye-bye.
Thank you.
Bye, everyone.